Hi, my name's Blair and I'm going to talk to you today about SVT and adenosine use. There are some things that we need to consider prior to using adenosine, and that is the rhythm that we've encountered if we've been called to a patient with moderate compromise and a tachycardia. We need to establish that they're not in a VT, which is generally in an older adult with or without heart disease, maybe a history of MI, and that it's VT is generally a wide tachycardia with a QRS greater than 0.14, may have capture beats, fusion beats, precordial concordance, and a tall V1 rabbit ears, left-sided rabbit ears, and it can have an extreme right-sided axis. They often present with severe hypotension, loss of decreased level of consciousness, and an increased work of breathing or quite short of breath. And they can be very compromised. Once we've ruled that out, then we've ruled atrial fibrillation out, which can look a lot like an SVT, especially as the rate increases. Remembering that atrial fibrillation is often irregular with a variable rate, and we need to be careful around atrial fibrillation because administration of adenosine to someone with atrial fibrillation can precipitate a VF. We can do a couple of things to ascertain. We can slow the ECG recording to 50 millimeters per second, and we can look at the variance in the rate over a brief amount of time, a minute or two. Once we've ruled those two rhythms out, we can include SVT in that it generally presents in a younger population, is generally quite regular and narrow complex, can be proximal onset, or the patient can be in and out of an SVT with a sudden onset, and may probably have a history of previous SVT, probably with the treatment with adenosine, and that's we can include adenosine in our treatment regime. So what is adenosine? Adenosine is an androgynous hormone that is formed by the breakdown of ATP. It can cause a transient block in the AV node by interrupting calcium and potassium channels, and also inhibits norepinephrine. So our indications are greater than 12, moderate compromise, heart rate greater than 50, that's a narrow tachycardia, and previously responsive to adenosine. Cautions would be someone with asthma or COPD, because adenosine stimulates mast cells to release histamine, and that can cause significant bronchospasm. And if they have a Wolff-Parkinson-White diagnosis previously, or we suspect Wolff-Parkinson-White on their ECG, then that could lead us down the track to ruling out AF. As I said, it can precipitate VT if we give adenosine in someone with that heart rhythm. So, what do we need to do prior to giving adenosine? We need to consider Valsalva, and remember that Valsalva may be indicated or may not be indicated in this patient. Or if Valsalva has been attempted prior to our arrival and hasn't worked, then we can consider adenosine. Remembering that Valsalva slows the conduction through the AV node and aids in atrial filling through a number of mechanisms. So we need to obtain serial ECGs. IV access, preferably in a large blood vessel, because adenosine has a very short half-life. So ACF, preferably 2 IV lines. Place pads in case things don't go quite how we like them, and some airway support. Low flow O2 initially, and making sure that we've got a bag valve mask ready if we need it. Adenosine comes in a 6 milligram and 2 mil preparation, but that will be our initial dose. We'll give that undiluted, followed by as a fast push, followed by a 20 mil flush. We need to give this a little bit of time to work. Onset is generally 5 to 10 seconds, and the duration of effect is about 10 to 20 seconds for adenosine. We should expect to see some sort of rhythm change within that time frame. If that first dose doesn't work, we can give a second dose. The second dose is 12 milligrams, so that's 4 mils, again as a fast push and with large saline flush following. Hopefully that resolves our compromising rhythm, and then we can manage causes and transport or not, depending on the patient condition. Thank you for your time.